Hello everyone. This course is a part of the project funded by the European Union and Russian Federation. The name of the project is Promotion of Breast and Colorectal Cancer Prevention Measures in Cross-Border Territories. The name of the course is Fight with Colorectal Cancer. My name is Denis Šimčikas and I work at Day Surgery Center of Republican Klaipėda Hospital, and also I work in Klaipėda University. This is the third episode of this course, and I would like to continue the talk about the performance measures in colonoscopy in our everyday practice. As a frame for this talk, I use great guideline published by European Society of Gastrointestinal Endoscopy in year 2017. In previous episode of this course, I talked about the sequence of the consultation. We talked about minor performance measures like indication for colonoscopy and time slot for colonoscopy. And now I would like to talk about the first key performance measure, that is rate of adequate bowel preparation. Rate of adequate bowel preparation is the percentage of patients with adequately prepared bowel. The rationale for this key performance measure is that it has been shown that the quality of bowel preparation affects the rates of cecal intubation and adenoma detection. Inadequate bowel preparation results in an increased costs and inconvenience as the examination has to be rescheduled or alternative investigations have to be organized. Minimum standards set by the group of authors of this guideline is 90%, and target standard should be more than 95%. Bowel preparation quality assessed using a validated scale such as Boston Bowel Preparation Scale, Ottawa Scale, or Aronchik Scale should be included in everyday colonoscopy report. If the minimum standard is not reached, analysis of the factors influencing bowel preparation should be performed on a service level. Information given to patients, dietary restrictions, cleansing agent used, colonoscopy timing. Boston Bowel Preparation Scale is the most thoroughly validated scale and should be the preferred one. Adequate bowel preparation may be defined as Boston Bowel Preparation Scale more or equal to 6. There is a separate guideline for bowel preparation for colonoscopy published by European Society of Gastrointestinal Endoscopy and updated in 2019. Of course, we all understand that very good results are possible only with very good bowel preparation. And especially it is important during a pandemic time. Repeated colonoscopy is increased number of contacts. Of course, we all understand also that in unprepared bowel, we cannot perform colonoscopy. And in poorly prepared bowel, we can miss the pathology. The colonoscopy would last longer in such bowel preparation. The time of sedation would last longer. There is a higher risk of complications as well. In such bowel preparation, we sometimes not only can miss the pathology, but it is impossible sometimes to perform the polypectomy. And we actually have the aim to find the pathology at the same procedure and remove it right away. Benign polyp is one thing, but actually in poor bowel preparation, we can miss the cancer, early cancer. It is an endoscopic view, narrowband imaging view, taking biopsy, and the specimen after the operation. How do we calculate Boston bowel preparation score? We divide the bowel into three parts: right, transverse, and left colon, and we calculate the score in each part separately from 0, very bad preparation, 3 points for great preparation, and the sum of three digits is the total score, which under 6 is considered as inadequate bowel preparation, and 6 and more is considered to be adequate bowel preparation. Worldwide accepted rules and the order from our healthcare minister says that the importance of proper colon preparation for colonoscopy is explained to the patient. All the necessary information about the preparation of the intestine for colonoscopy is provided to the patient by the doctor who sends the patient for a colonoscopy. The patient is given a leaflet. It means we must explain to the patient and give the explanation in written form as well. When there is 1 day left, you should stay on liquid diet only. And again, no seeds, no nuts. Because what happens is they occlude the colonoscope and you can do nothing. Preparation. In other words, cleaning solution. Cleansing solutions are classified according to volume, osmolarity, and main active ingredient. There are high volume and low volume solutions. There are isosmotic and hyperosmotic solutions. The example of isosmotic solution is polyethylene glycol. Hyperosmotic solutions are sodium phosphate, magnesium citrate, sodium sulfate, sodium picosulfate. The ideal preparation is safe, which does not cause water electrolyte imbalance. Effective, it means cleanses the intestine quickly and cleanly. And well tolerated, it means delicious and easy to drink. The isosmotic preparation is polyethylene glycol. It is still sometimes called the gold standard. It does not resorb and does not cause redistribution of fluids and electrolytes and can be given in the presence of electrolyte imbalance, in heart failure, in renal failure. Polyethylene glycol has appropriate security profile. It is effective, but the negative thing is that it has large volume and not very tasty. Sometimes 4 liters of the solution is not that easy to drink. That's why we have hyperosmotic solutions. They have lower volume, but some preparations are less safe compared to polyethylene glycol. And we should be cautious when prescribing for the patients in the presence of electrolyte imbalance, in heart failure, in renal failure. In Lithuania, biggest opponents are sulfate solution and sodium picosulfate with magnesium citrate. If you consider to prescribe for the patient one or another, before that I highly recommend to read the recommendations about those solutions of European recommendations of European Society of Gastrointestinal Endoscopy and American Society for Gastrointestinal Endoscopy. And I recommend to look through the point of view of safety, efficacy, and taste. Safety includes contraindications and reported side effects. Efficacy is the quality of bowel cleansing. And for me, safety is first. I'd rather drink not very tasty solution, but do not have side effects. I will not go too much in detail about the contraindications and side effects, but I highly recommend to read about it before you prescribe one or other solution for your patient. Another issue is bubbles. In the case of many bubbles, we can miss pathology as well. Like in this case, we can see we washed the bubbles out, there are left some, and we found adenoma. To prevent bubble formation, we recommend to drink simethicone with the last glasses of water. And the last thing about the bowel preparation is regimen, how to drink the cleansing solution. Possible preparation regimens are all doses the day before the study, divided doses, it means half in the evening and half early in the morning, and all doses on the day of the study. There are publications, and we can see it clearly in our clinical practice, that divided dose compared with full dose in the evening significantly improves intestinal preparation, tolerance, decreased nausea for the patient because half of the volume patient drinks in the evening and another half in the morning. And also, the frequency of finding flat polyps was increased using divided dose regimen. In the evening and divided dose regimen. And what are our results in adequate bowel preparation? We started to perform colonoscopies in our day surgery center in February 2021. In the last 8 months, we performed almost 500 colonoscopies. We calculate the score of Boston Bowel Preparation scale in every single colonoscopy, and we analyzed the data of our very first 50 colonoscopies. And it appeared that we have adequate bowel preparation in 96% of the cases. And ESGE's recommended standard is more than 90%, which we actually achieve. Most common cases of inadequate bowel preparation are because of that patients do not follow the diet and regimen which doctor recommended. And again, it is important to take time to explain the diet to the patient, select your preparation, and select the optimal preparation regimen. This is the end of the talk about the rate of adequate bowel preparation, and in next episode I would like to talk about the completeness of the procedure. Thank you very much for your attention.